for the introduction. All right. I just watched Terminator, so hearing my laptop talk to me just kind of freaked me out, but recording is in progress. It's good. We're all up to date on that.
Is that right? Danny's got it going. Okay.
Okay. I'm going to be talking about the cellular organization of tumor regression, neoadjuvant anti-PD-1 treated non-small cell lung carcinoma. And if you're like me, you didn't read that whole title, but hopefully all the words are going to make sense by the end of this presentation. Does anybody know what this is? No guesses? I had somebody say toxic waste. Um, this is a multiplex immunofluorescence slide of a lung tumor. And hopefully by the end of the presentation, you'll be able to talk intelligently about it. And you can tell your parents all about it when you get home. I'm going to begin the talk by talking about the tumor immunity cycle. And this is kind of a busy diagram. So I'm going to say in broad strokes, we begin with tumor. We'll venture off to the lymph node, enter then the vasculature, and at some point in time, we'll return back to the tumor to kill it. And getting a little more specific, forgive me if you're online, I'm using a laser pointer and you're not going to see it, but you have the advantage of being an inch from your screen. We begin with the tumor that releases aberrant proteins or an aberrant expression of protein. This is picked up by antigen-presenting cells, such as dendritic cells. They bring it to lymph node, where it is brought to our lymphocytes, our T's and B cells. These are primed and activated, ready to fight and kill the tumor. They travel through the bloodstream back to the site of the tumor. And ideally, they recognize the antigen expressed on the tumor and they kill it. And I've mentioned that this is canon, this cycle, starting from the tumor off to the lymph node, blood vessel, back to tumor. But in actuality, we're starting to appreciate that we don't need to go all the way to the lymph node, and this can happen locally in tertiary lymphoid structures, but more on that later. We're going to focus on this part here, where the immune cells target antigen that's expressed by the tumor. They recognize danger, and then they kill the cell. Tumors are, through evolution, they've learned how to dupe the immune system into thinking it's not theirs, avoiding the recognition and thus avoiding the death. And one mechanism that they do this is through the PD-1, PD-L1 pathway, where tumor cells, such as this big orange blob, may upregulate PD-L1, which stands for protein death ligand 1, which will bind PD-1 on, in this case, a T lymphocyte, initiating anergy in the T cell. But we can block this interaction with an anti-PD-1 monoclonal antibody, thus resulting in the tumor's death. And so here's a timeline of neoadjuvant anti-PD-1 immunotherapy being administered. Starting from diagnosis, a biopsy is taken, the biopsy is analyzed. If the biopsy contains sufficient PD-L1 expression, then they're a candidate for anti-PD-1 immunotherapy. In the neoadjuvant setting, the therapy is administered prior to surgery. This allows the immune system to become sensitized to the tumor, hopefully clearing it to some sufficient degree before surgery. And another benefit is that it wards off metastasis afterhand because the immune system's been sensitized to the tumor before it was cut out. And this is associated with improved event-free survival. This is a recent phase, well, recent enough, phase 3 clinical trial that showed more than 50% improved event-free survival using anti-PD-1 plus chemo versus chemo alone. Another benefit to neoadjuvant treatment, especially for research, is that we get to evaluate how much the tumor shrunk, how much did the immunotherapy do to the tumor before it was cut out. And so we use this as a surrogate for response. We can evaluate patient response by the amount of tumor left in the tumor bed. Unfortunately, you can't see the title. So that would be awesome. Is that what this is? Oh, yeah, there we go. Amazing. So this is from work from my mentor, Trisha Cottrell. These are multiplex immunofluorescence images showing the extremes of response to anti-PD-1 immunotherapy in the neoadjuvant setting. These are all taken at the time of surgery. On the right-hand side, uh, you see there's no tumor remaining. What's annotated in blue is all where the tumor has regressed. And in its stead, we have the formation of these tertiary lymphoid structures that support the local immune response. This is called pathologic complete response, and we say there's 0% residual viable tumor. On the opposite end of the spectrum, you see annotated in green a large chunk of tumor that hasn't at all been degraded by the immune system whatsoever. A critical threshold is 10% residual viable tumor that marks major pathologic response, and this is associated with improved outcomes. We all clear on RVT? Because I'm only going to start saying RVT. Yeah. Has this thing died? That's so sad. There we go. Okay. So, right. So it's easy enough to evaluate RVT when the tumor glows orange and it's annotated in green and the regression bed is annotated in blue. But really, pathologists are staring at this. Looks like a bruise on my leg. And so this is a microscopy slide that's been hand annotated. And so we're talking about centimeters here that somebody has drawn on regression, normal lung, and tumor. And you can see just below it, the distinction between normal lung and tumor regression involves a comprehensive analysis of a constellation of features. And what we're seeing on the right-hand side here of this, this is all connective tissue, fibrosis. And on the left-hand side, this is normal alveolar lung. And what pathologists are looking for, signs of tumor cell death, would be cholesterol clefts and foamy macrophages. And in its place, a scar forms. And characteristic of scars would be fibrosis, like I mentioned, collagen, and the formation of new small blood vessels, neovascularization. But it's important not to think of this as just a cold scar because it's highly infiltrated with immune cells. You can see on this image, if you've looked at an H&E before, you see these little tiny purple dots. Those are all immune cells. And we had mentioned tertiary lymphoid structures. These form preferentially in regression and help sustain the anti-tumor immune response locally. And so I'm going to talk a little bit more about them. A tertiary lymphoid structure, or a TLS, as I'm going to start calling them, resembles a lymph node B cell follicle. And so again, these are multiplex immunofluorescence images showing on the left a lymph node follicle and on the right a tertiary lymphoid structure that's adjacent to tumor. And in both cases, we have this ring of B cells surrounding what is very likely a pool of dendritic cells and other APCs. And it looks like there are PD-1 expressing cells, so possibly helper T cells. And we see this pattern in both the lymph node follicle and then the tertiary lymphoid structure. And this is different from just a pile of cells that happen to be in close proximity because this is structured and organized. And the structure and organization allows B and T cells to meet. It allows dendritic cells and B cells to meet. Thus, we have antigen presentation and priming occurring. And then upon priming and activation, we have clonal expansion. So they're like B cell factories, basically. And these being proximal to the tumor are a supply of lymphocytes. And so my hypothesis is that the durability of response to neoadjuvant anti-PD-1 in non-small cell lung carcinoma is driven by the quality of immune niches formed in the tumor regression bed, not the extent of tumor regression alone. So we're talking about quantity, but also quality. To answer this question, we are analyzing lung resection specimens from neoadjuvant anti-PD-1 treated lung cancer. We have 19 specimens. This is from the first. I should mention that neoadjuvant anti-PD-1 is not standard of care. This isn't typical treatment. What we have is our specimens from the first clinical trial of neoadjuvant anti-PD-1 in lung. And so they're quite dear specimens. We only had 35, and we cut this number down to 19, only those specimens that exhibited any kind of tumor regression. So very rare specimens, not something that I can go into CoPath or whatever it's called now and search up. And we've stained them sequential sections from each tissue block. We've stained with two multiplex immunofluorescence panels. Panel 1 is targeting the PD-1, PD-L1 axis, and it's got players on it like PD-1, PD-L1, FOXP3, measuring our T regulatory cells, CD8, our cytotoxic T cells, CD163 would be our M2 leaning macrophages and a tumor marker. And the second panel is going to help us define features of the regression bed. It's also got PD-1, but it's got CD79A. That's a component of the B cell receptor, and it's expressed on B cells. CD3, that's our pan T cell marker. ERG, as I'm calling it, is our marker of microvasculature. CD163, as I mentioned before, are M2 leaning macrophages. So the macrophages associated with tumor progression. This is all processed through AstroPath, and I interact with the data through SQL and Python. So what's AstroPath? Doctors Janice Taub and Alex Saleh at Johns Hopkins University are combining experience in physics and astronomy. That's Dr. Alex Saleh. He worked on the Sloan Digital Sky Survey, and Janice Taub is a dermatologist at Johns Hopkins University and expert in pathology. And what they found working together is actually there are a lot of parallels between astronomy work and high intensity. Okay, high intensity. What's that noise? Somebody got IBS or something? All right. Anyway, a lot of parallels between astronomy and pathology. Specifically, we're taking massive data intensive photos. We're segmenting things into individual pieces, and we're phenotyping. We're declaring an identity for each of these things, and we have to store them in a giant warehouse, data warehouse, a database that we can use to interface with the data. And so this all to say that none of this would be possible. The scale and the fidelity with which we are approaching this question is only possible because of their work. So what did we find when we take a look at these specimens? Again, this is a multiplex immunofluorescence image of a tumor. The regression bed has been annotated in blue, and the residual tumor is annotated in orange. Does anybody notice, if you were to chunk this into zones, what would you describe? Nobody? Yeah, you pointed at it. I know you know it. Yeah, definitely. And we noticed a consistent pattern looking across multiple specimens that there's this infiltration of immune cells adjacent to tumor marked by CD8, CD3, CD79A, and macrophages. Consistently in all specimens, there is this ring of infiltration around the tumor, and we are calling that zone 1. We also notice I was talking about scar formation. This is the wound healing zone. It's low cellularity and high relative proportion of ERG, which is our marker of vasculature, and CD163, which is associated with wound healing and cleaning up debris. And then we also noticed pocked throughout the regression bed tertiary lymphoid structures, annotated in these green circles. And we've talked about them before. They contain lots of B cell materials, some T cell material, CD8 and CD3. And we think they're important for response. Now, the question is, we can identify those visually, and a pathologist can recognize this intuitively, but how do I define this quantitatively and operationalize it across all the specimens in my data set? How do we define it? So here's how I started. This is a heat map of all the T cells in the regression bed of a given sample. Where it's darker, it's more dense, and you can see that around the tumor, there is a thick band of dense infiltrate. This is our zone 1. And as we look out to the other section of tumor, you can see it's approximately uniform all around the tumor. So what this inspired me to do was just to draw a barrier around the CD3 high density zone, which we call zone 1, and everything outside that zone we call zone 2. Any questions? Would anybody do it better?
I have your previous slide. So between, what is this here?
Right.
I thought you were gonna say that was the PLS, but
No, it's not a TLS, it's not tumor. It's probably like a vessel of some kind. It's hard to see at the resolution. We'd have to like zoom in. I think, Trisha,
It could be an airway.
airway, possibly. Right, so we use the CD3 density to define zone 1. I did this visually for every specimen. That's the beauty of having a small cohort. I can do stuff like that. And so we have this bespoke uniform distance for every sample that I visually validated. And that's what it looks like. For zone 3, our tertiary lymphoid structures, the challenge was being able to be consistent, to capture every TLS and not miss any TLS, and to not capture things that are just dense regions of B cells. And so here now we're looking at a heat map of CD79A, our B cell marker. And I've annotated zone 2. And inside you can see these splotches of high density zones. I applied a clustering algorithm. I meant to write this out underneath, so my apologies, but it's hierarchical density-based spatial clustering of applications with noise. And I'm sorry if that means anything to you. Right. And so what did that look like? Well, I think it did a pretty good job. I was trying to be perfect, but perfect's not what we're aiming for. We're looking for something that will do a fair enough job and represent the tissue at the specimen level. You might notice that there's a little blip that's missing. And I was saying the challenge is to make sure that we're capturing all the TLS and not getting something that's noise. And so when I looked at this the tissue section in the full color image, I noticed that this was not, in fact, a tertiary lymphoid structure. It was just maybe there's a vessel or something there, and there are a lot of B cells adjacent to the vessel. So to avoid things like this, I applied some criteria to the clustering. A minimum cell sample of 50. So you have to have at least 50 cells to call that a TLS. The density must be at least 1,000 cells per millimeter squared. I had to vary this for some samples that had just high density. Minimum size, so 0.1 millimeters squared. And this is all in case you want to go home and do this clustering, you now have the numbers to do it. Um, and so this was not something that I ran on all the specimens at once. This is again something that I did specimen by specimen, looking at it visually, making sure that I had it was capturing what I wanted it to capture. And in the literature, so we have only a finite number of markers on this panel, and we can't assess the maturity of a TLS. And what they use in the literature, if you have mixing of B cells and dendritic cells, that automatically qualifies a TLS as mature. You might think, why don't you use size? Well, we're cutting into the tissue and we have this 2D representation of a 3D mass, and who's to tell that we have the middle of the TLS where it's thickest, or we've skimmed the top of it and we have something really small. So I didn't consider size in estimating maturity. You can assess whether or not TLS is mature via H&E uh, by whether or not it has a germinal center. And so possibly a next step for this would be going back to the H&E and deciding which of these clusters is mature and not mature, but I'm not there yet. So any questions about this one? Yeah.
So in addition to B cells, though, you mentioned dendritic cells. Are there those and other types of immune cells that you need to see there to categorize it as a TLS?
Right. So in a paper published recently in Lab Investigation, the minimum requirement for a TLS was just at least 50 B cells. That was it. You can call that a TLS. And that would be immature if it did not have dendritic cells, mature if it did. Yeah.
Sorry, real quick. Belabor the point, but can you clarify for me, so at your northern border there, for example, the TLS that you circled?
Yeah.
Yeah, that one. So compared to some of the other ones where the ring is sort of around more tighter clusters, there are a couple that look like that where there seems to be more of a,
Right.
there might be another little cluster sort of epicentric to it. Can you explain why it's not two individual circles as opposed to one?
Yeah. So functionally, how this algorithm works is it's density based and it works its way out from the densest. So every cell becomes a data point in this, and every cell has a local density that's out to a certain distance. And we evaluate that distance, that density to a certain number of neighbors and to a certain distance. And so if you meet the number of neighbors, um, extend the boundary of the annotation. So what's happening here is that these are too close that they just call them as combined versus, for example, this and this are far enough apart.
Okay.
In the package that I used in Python, I can change that distance so that I can aggregate further away clusters, but I can't do the opposite. So I can't split them. What's happening here though is maybe this heat map isn't too fantastic because it looks like this is a high dense region and this is basically nothing. But when you go and you look, you see this high density region, and then you see sort of a waft of B cells in this area. So they're still there. But thanks for the question. Right. So we operationally defined all the zones, and here they are for one given specimen. And the color coding here is the same as the color coding in the graph. So we analyze now across multiple specimens the CD3 density in zone 1, 2, and 3 to make sure that we saw differences. And as we expected, the CD3 density is highest in zones 1 and 3 and lowest in zone 2. And we repeated this for our other markers, CD79A, which had its highest density in our tertiary lymphoid structures, CD163 had its highest density in zone 1, followed by zone 2, our wound healing, and the density of vasculature was approximately equal in each zone. So now that we've defined the zones, we know that they're different. We wanted to go look at the differences between patients that responded and didn't respond. And that's what this is, looking at zone 1 exclusively. And again, I'll start with CD3. There's obviously a trend in higher densities in non-response, which we wouldn't intuitively expect, but it's not statistically different. And I'd like to point out that we started with 19 specimens, and now I'm grouping them by response, and we only have 8 non-responders and 11 responders. MPR is major pathologic response. And for the remaining markers as well, no statistical difference between what we see in response and non-response. Everybody good with that? All right. Interesting. So looking at density is one metric, looking at cell proportions is another. When we look at the proportion of cells in zone 1, we see that approximately the CD3, CD79A, and CD163 relative proportions, this inner pie chart, it's about equal in response and non-response. The proportions are about even. This second ring is describing the subsets of CD3 cells. Now we're looking at within CD3, CD8, FOXP3, our regulatory T cells, and other not phenotyped by our panel. And these are probably helper T cells that are CD4 positive. And what we notice, obviously, is that there are way more CD8 cells proportionally in major pathologic response compared to non-response. Interesting. When we do the same thing for zone 2, we see again, now I'm showing densities, not proportions, for each of these markers. We see that the densities are not significantly different in response versus, in non-response versus response. Any thoughts on that? Okay. Just got to make sure, I don't want you to bottle up any questions. Zone 3, we do the same thing for zone 3. And again, no significant differences between what we see in response and non-response. However, maybe the densities of the cells don't matter, and that's what the data is showing us. But when we look at so now these are scatter plots. And I'll begin by talking about the one on the left. When we talk about the zone area, so this is the surface area of TLS in the regression bed, we see that higher surface area is associated with higher, this is overall survival, OS. So in other words, more surface area of TLS, better outcomes, longer survival, and this is statistically significant. On the right-hand side, we're looking now at the density of TLS in the regression bed. That's on the x-axis. And if we look at higher densities, we're looking at lower RVT, which is on the y-axis. And again, this is statistically significant. So we see that higher densities are associated with reduced residual viable tumor, or in other words, better outcomes. And again, more surface area of TLS in regression is associated with improved survival. And so here's a little summary of everything I've talked about so far. All responses appear to have the same fundamental regression bed architecture, the zones we've talked about. Zone 1 is that high CD3, CD8, and CD79A adjacent to tumor. Zone 2 is the low cellularity, high ERG and CD163 proportion. Okay. And zone 3 are the tertiary lymphoid structures. And what we found is maybe that the number and size of tertiary lymphoid structures may be a surrogate for a robust immune response that correlates with patient outcomes. And what I hope to look at next will be the tertiary lymphoid structures in response and in non-response. I have a few next steps. I'll try not to get too crazy into it. Um, I don't know if you can tell, but I'm pretty excited about this data. I don't know. People told me I sound depressed when I talk. So now I'm like, I am depressed, but I'm also like excited about this data. Um, anyway, so one of my next steps, I want to look at the T cell activation states in TLS, and I want to interrogate this in response and non-response. How are we going to do that? We stained these specimens with another panel. I hid it from you for simplicity. It's got TBET, which is a transcription factor, granzyme B, EOMs, eomesodermin is another transcription factor. Granzyme B is what's involved in T cell mediated death of other cells. LAG3 is another immune checkpoint molecule, and CD8 is our marker for cytotoxic T cells. PD1 is our canonical immune checkpoint molecule. And I'm really interested in these two transcription factors, eomesodermin and TBET. This is another paper that showed the relative expression of EOMs and TBET associated with the phenotype of the cell, either exhausted or memory-like. Um, what they showed is that a high EOMs to TBET ratio on the right here is associated with cell exhaustion, and a low EOMs to TBET ratio is associated with the memory-like phenotype. And so again, I'm just keeping this up here so you can see it. Now what we're looking at is data from my cohort. I took all of the cells and did a bit of a flow cytometry type analysis. So now we're ignoring the spatial. We're just looking at the cells themselves, and we're looking at the fluorescence intensity of these two markers. So here we can see I've plotted the intensity for eomesodermin, and you can see it's bimodal. I've plotted also the intensity for TBET, one peak, and here is the ratio, retains the bimodality, splitting us into two populations of EOMs to TBET high and low. And when I examined cells at the very extreme end of exhaustion, oh, I forgot about this one. So exhausted cells are associated with improved survival. When I look at the cells that are in patients that lived long without recurring, this is recurrence-free survival in the blue line. They lived long. In the red line, they did not live long. And you can see there are stark differences in the expression of the EOMs to TBET ratio in the two populations. So that tells me that something's going on. And this is another plot showing the most exhausted cells. So the proportion of CD8 cells that are EOMs to TBET very, very high is strongly associated with reduced residual viable tumor. And you might be thinking, why is a good outcome associated with exhaustion? And the theory we've put together is that there was tumor, the immune cells came, crushed the tumor, wasn't even close, and then they got exhausted. And so we're seeing that lots of exhaustion is associated with what had formerly been an excellent response to tumor. Another thing I'd like to look at, totally unrelated, we have some pretreatment biopsies from the same cohort. And I'd like to look at tissue remodeling from the pretreatment biopsy to the on-treatment surgical resection so that we can study the effects of therapeutic pressure and we can better understand response in terms of tissue remodeling. So I think now I've hit time. So I'll just stop right there. But actually before that, okay, does anybody know what this is now? Geez, just Blank stares, tumor. That's our zone 1 regression. This is our zone 2 of regression. And these are our tertiary lymphoid structures. So thank you everybody for coming. That's all I've got.
Okay, lots of time for questions.
Yeah,
Nice work, Michael.
thank you.
I had a question about, I guess, what you're essentially looking at with these TLS structures. And I was wondering if they're a bit more of a glimpse into what had happened over the course of treatment. Is it like as the tumor's regressing, there's a TLS like very close to the tumor, and then as that one gets left behind, the tumor's regressing, a new one forms, and so on and so forth. Or if, I guess, the remaining TLSs in the zone 2, or I guess that make up zone 3, are still actively contributing to the immune response, I guess, through the treatment period.
That's an interesting question. And one of the, so maybe I'll repeat it so people can hear. Marco was just asking, are all the TLS involved in an active immune response, or are some of them just an artifact of what had passed? And one way we can address that is by looking at the age of the TLS, and we can do that by assessing its maturity. And we can look at whether the newly formed TLS are consistently close to the tumor, away from the tumor, where they are spatially. Um, in my observation, the smaller and the not germinal center having TLS are more proximal to the tumor than the mature. But when we look at the tissue section, obviously we still see a wealth of B cells and T cells there. So it's not to say they're not doing anything, but I think you may be onto something that they are from a former period of the immune response. Thanks.
Yeah, please, Michael. So very nice, and thanks for explaining. In terms of what you're planning to do, to go back to the pre-biopsy specimens as well, to look at those sort of dynamics, maybe it's playing on what Marco was suggesting. Do you think you'd be able to also tease out areas in the tumor that around which the TLS that you think might have been the most active to facilitate the regression in the responding samples, will give you clues to whether or not there are different areas within those types of tumors that might be focused on for more fine tuning of response measurement in the future? Do you know what I mean?
Yeah, I see what you're saying, and I think what's kind of exciting is that I am interested in looking at tumor clonality, and so maybe if we can establish where the architecture of the tumor is different, having experienced the treatment, and we can look for pockets of the tumor that are resistant, maybe, and we can try to suss this out through the spatial analysis. But I think it's hard to look at. There are too many layers to be able to say, oh, it's because this TLS, or
Sure, but I was thinking more, subtly, if there were some tumor stem cell like markers that you could focalize on, and maybe the TLS that are the most correlating with clinical responses are the ones that are occurring near those stem cells, and removing those so that the tumor can't actually regenerate itself.
Right. I would love to stain this panel or these specimens with a whole lot more panels.
Sorry to give you more work.
No, but we're kind of limited because this was done like what, Trisha, like 3,000 years ago or something like that. So yeah.
I think Maduri Kochi has a question. Go ahead, Maduri.
Hi, Michael. That was a
Hello.
really nice presentation. TLSs are my favorite structures in tumors, so I really enjoyed learning more about it from a different context. So have you looked at plasma cells around in your TLSs?
Can you repeat the question? Yeah, so the question was, have I looked at plasma cells. And so we have a marker for plasma cells. We have CD20 on another panel, but it wasn't stained on these specimens, so I can't specifically subset those.
But you
But
could look at just the H&Es because plasma cells are so distinct. You could probably identify those in your H&Es because it seems like you have plans to go back to your
yeah,
H&Es. Yeah, I think that would be a good direction. Another thing is, have you done any cellular neighborhood analysis? For example, when you have clusters of certain cell types in your panel, looking at what were the other cell types in the nearest neighborhood when TLSs are close to the tumor epithelium versus they are distant. Because I do see in your full section there are some TLSs that are quite distant, right? Because of some chronic inflammation going on there. So have you done some neighborhood analysis there, like in terms of what are those, if there are any differences?
right. So the question was, have I done any neighborhood analyses to assess whether or not the TLS are different in different regions of the tumor? And I haven't done it specifically for TLS, but another aspect of my thesis project is looking at the spatial configuration of immune cells in relation to tumor. And I'm able to extract these cell neighborhoods and use them as proxies for various outcomes. And maybe what I should do is identify the neighborhoods associated with um, more or less TLS or the maturity of TLS.
Mhm. A last question, very quickly. My favorite question is how many females and male, what was the distribution, sex distribution in your cohort?
Yeah, it's about even.
Is there any difference there in terms of infiltration of
Male,
these
female.
CD79A positive cells?
So the question was, do I have the same number of males and females? It's about the same. And then the follow-up question was, is there any difference in anything that I've measured? And so I included sex in all my analyses as a covariate, but I haven't seen any significant associations, which may be a numbers problem, or maybe it's just not strong enough to be teased out.
Or maybe it's not there.
Yeah,
Great. Really enjoyed. Thank you.
thank you.
I don't know.
I have a question somewhat tangential to what Filippo was asking. If you look at zones 1 to 3, is there any correlations that you expect to see either with the cell composition and the infiltration of the remaining viable tumor, or perhaps of that tumor body that is now regression, but perhaps what was going on there before the regression happened?
Any correlations I'd expect to see in the specific zones?
Well, between zone 1 and 2 of the regressed tumor, either say if you see, I don't know, a lot of B cells or T cells, would that also be the case in the tumor pre-treatment, or perhaps have correlations with the infiltration into the remaining tumor too?
It would be interesting to see if it's the same pretreatment. I will say that our pretreatment samples are very small and our on-treatment resections are massive, so it's not an apples to apples comparison. But I think keeping an eye out for things that correlate is always the science that is the science, right? So thanks.
So I was curious, you mentioned that dendritic cells are something that indicates whether or not the TLS is mature. Have you included dendritic cell markers in any of these analyses?
We have a panel that's in the works that may or may not wind up having one, but no, we have not looked for them.
Really?
Very cool talk and well, a question. The zone 2 looks like kind of like a no man's land, like a desert. There's not even any TLSs in there. Is there like I'm just trying to get my head around the fact that it almost looks like the body doesn't need to protect that space. Well, there are TLSs.
Yeah.
I thought you were gonna ask about zone
there-
one, because so there are no TLSs in zone one. You exclude TLS from that category. This is mostly inflammation, but that's T
There's no
cells.
lymphocytes, so aside from the two. Right?
Is it, there are some to a lesser degree, yeah. And that would be on this.
I'm just wondering if it's sort of undefended territory or if those kind of like watchtowers with TSs.
Right.
I'm trying to think of how to think of this in war terms.
That'll be awesome for when they make a movie out of this.
Just get fibroblasts.
So we don't want the army to be able to see. I don't have an hypothesis.
Any other questions? If not, thanks very much, Michael.